So coming to transplant surgery, coming to donors. So let me take an idea about what do you know about transplant surgery. Anyone from the class? What do you mean by transplant surgery? What do you think? What gives a rough idea about transplant surgery? Speak up. If you are wrong, I am going to correct you. It's a small group discussion, I think. So we are going to discuss. Okay. So what do you mean by transplant surgery? What an idea, what a rough idea you have about it. Okay. So you know you are going to transplant an organ from one donor. So you know what is a donor and what is a recipient. That idea you have. Okay. So coming to donors. So the donors, there are of two types, living donor and dead donor. Okay. So most transplant organs are from the deceased donors. What do you mean by deceased donor? Disease means dead. Deceased donors, of which they are of two types. Donation after brainstem death and donation after circulatory death. DBD, DCD. There are of two types of deceased donors. They are DBD, DCD. Living donation is limited to kidney, liver and lung transplantation. Means you can transplant these organs in when the donor is living, not dead. Okay. Donation after brainstem death. Okay. What do you mean by donation after brainstem death? Brainstem death occurs after severe brain injury. The brainstem death occurs after severe brain injury. Okay. As a result of either trauma or a cerebrovascular accident. So what do you mean by a cerebrovascular accident? Yes. Potential DBD donors, what is the full form of DBD? Donation after brainstem death. Donors are in apneic coma. What do you mean by apneic coma? No respiration. Okay, means the patient cannot afford to breathe himself or herself. Okay, that requires mechanical ventilation. That's why we are giving mechanical ventilation on the intensive care unit. There must be a known cause of irreversible brain damage demonstrated by a CT scan. So, donation after brainstem death. What do you mean by brainstem death? Patient will be in coma, in apneic condition. He will be requiring a positive pressure ventilation. Okay. So, that means the patient is in a brainstem death and you have to confirm it by CT scan. Okay. Now, brainstem death is defined as the permanent loss of the capacity for consciousness and spontaneous breathing. These two essential functions are controlled by the brainstem, you know. So, in this situation, the circulation can be maintained for a period of time after death, and donation, brain dead donors were previously called as heart beating donors. Why? The heart is still pumping. In most countries, it is accepted that brainstem death equates to medical, legal and religious terms to the death of the patient. Means it is considered that if a person is brain dead, that means he is acceptable, that body is acceptable, that person is believed to be dead. Okay, that's why that patient is fit for organ donation. Now coming donation after circulatory death. So donation after circulatory death describes the recovery of organs for transplantation after death confirmed by a circulatory criteria. These donors were previously called asystolic or non-heart beating donors. Okay. The modified Maastricht classification is widely used to categorize donation after circulatory death. I will be coming to the classification. So there is a classification of DCD. Okay. So organ donation after unexpected and irreversible cardiac arrest is referred to as uncontrolled DCD. So you will be now studying about, see, we are talking about DCD, means donation after circulatory death. Now DCD is classified into two types. First is uncontrolled DCD and another is controlled DCD. What is uncontrolled DCD? Organ donation after unexpected and irreversible cardiac arrest. This is referred to as uncontrolled DCD. So then what is controlled DCD? Controlled DCD is organ donation after death resulting from the planned withdrawal of life-sustaining cardiorespiratory support. Is it clear to everyone? Now coming to controlled DCD donors. The controlled DCD donors are ICU based, okay, and they have suffered massive and irreversible cerebral damage but have an intact brain stem, so that they are self-ventilating. They are self-ventilating, okay. In a situation where further attempts at treatment would have been of no success, the withdrawal of the supportive treatment leads to cardiorespiratory arrest, okay. That means a person is not taking a breath on by himself or herself. We are putting the patient on mechanical positive pressure ventilation, okay, mechanical ventilation. So if we remove that support, that patient is going to collapse, okay. So this is this is a irreversible condition. So and this usually occurs within a short period of time. This is the classification which I am talking about, and this is important. This is Maastricht classification of dead donor. So here you can see there is class, presentation, situation and organ which can be procured. See, in class 1, the presentation of the patient is dead on arrival, okay, and the situation is uncontrolled, okay. So the organs which you can take from this patient is heart valves and cornea. Coming to class 2, the patient, there is a unsuccessful resuscitation. Now what do you mean by unsuccessful resuscitation? What do you mean by resuscitation first? Resuscitation means a attempt to save the patient, like cardiopulmonary resuscitation, okay. So if that is unsuccessful, okay, then what you can organs that patient can donate? Kidney, heart valves and cornea, okay. Class 3, now it is a controlled situation, okay. So it is anticipated that the patient is in cardiac arrest, okay. So you can take all the organs except heart, because it requires, heart donation requires beating donor, okay. So class 4, coming to class 4, cardiac arrest in brain dead donor, okay. Now this situation is also controlled. This is controlled. I told you about the classification. Controlled DCD and uncontrolled DCD. Now just tell me what is controlled DCD. What is controlled and what is uncontrolled? Withdraw করে দিলে কি হবে? So the situation over here is, what do you understand? In class 3, anticipated cardiac arrest and the situation is controlled. What do you mean? So in that case, what organs can be procurable organs are all organs except heart. Now coming to class 4, cardiac arrest in a brain dead donor, okay. In this patient, all organs are procurable except heart. In class 5, unexpected cardiac arrest in a hospital patient. So it is an uncontrolled situation and you can procure all organs except heart. This is a classification of a dead donor, okay. Now coming to contraindication of organ donation. The contraindications are, they include active systemic sepsis, okay. Now what do you mean by this? Active systemic sepsis, ongoing infection, and transmissible infection. What do you mean by transmissible infection? Spreadable disease, okay. Now the malignancy, when you cannot, this is absolute contraindication. Malignancy within the last 5 years, with the exception of tumors that do not metastasize. So what are the tumors that do not metastasize? They are primary brain tumors, non-melanotic skin cancer and in situ carcinoma of cervix, okay. Like in this situation, the tumors which do not metastasize, you can consider that patient to be a donor, okay. Now coming to contraindication to organ donation. It's a continued slide where you can see organs from high risk donors. The high risk donors are donors with meningitis, encephalitis, HIV, patients suffering from HIV, hepatitis B and C. See, now they can be transplanted safely. Organ from these patients can be transplanted safely and they yield the transplant outcomes from a normal patient. Means the normal patient from whom we are procuring the organs and the patient who are suffering from these diseases, transmissible diseases, we are procuring the organs, the result is almost same. But still there is a chance of infection to whom? To a recipient. So the donors have, so the recipient has a chance of having this bloodborne infection. And why do you think that in spite of knowing this, that the recipient may land up into that same bloodborne infection, still we have to consider why? In which situation? When there is scarcity of donor. If you have no donor and it's a life-saving procedure, you have to save the life, okay, then you can consider. Is it clear? Now coming to types of graft. So autograft, what are the types of graft? Autograft, isograft, allograft and xenograft. So what do you mean by autograft? Graft from the same person. Means suppose he is a person X, I am taking a skin graft from his leg and applying it to his thorax part, okay. So that will be called as autograft. Then what do you mean by isograft? Is graft between the identical twins. Suppose he has a brother, they are identical twins, okay, and I am taking, procuring some organs, suppose kidney, and I am transplanting it to X person, okay. So that means that will be considered as isograft. So what do you mean by allograft? Graft among same species. In this same species, what do you mean? Human to human. That means suppose X is a person and Z is cousin brother or cousin sister, and I am taking her kidney and I am giving it to X patient. So this will come under allograft, okay. So come to xenograft, graft between different species. What do you mean by this? Yes, suppose transplanting anything from monkey to a human, okay, that can be considered as xenograft. Coming to orthotopic and heterotopic graft. See, orthotopic graft is a graft which is placed in its normal anatomical site in the recipient, just like a liver transplant. So what are we doing in liver transplant? We are taking a part of a liver from a donor and giving it to the recipient. Where we are placing that? I am thinking now about the place where I am placing. I am placing it in the normal anatomical position only. Okay, this is called as orthotopic graft. And what do you mean by heterotopic graft then? A graft is placed aside from that where the organ is normally located. For example, a kidney transplant in right iliac fossa. Suppose, what do you think when you are transplanting a kidney? What do you think? Suppose a person's right kidney is not working, okay. So what do you think? He requires right kidney and left kidney. Obviously, a person needs a transplant means both the kidneys are damaged, okay. So what do you think? Where is the new kidney from a donor is placed? What do you think? Both the kidneys are removed and then placed over there? No, it's placed in a different site. Where? In a iliac fossa, okay, preferably in the right iliac fossa. A person can survive with one kidney, so it's placed in the right iliac fossa, okay. So this type of site will be called as heterotopic site of the graft, okay. So coming to organ packing, see, you are retrieving an organ, you are procuring an organ from a donor and giving it to a recipient. So there is a gap between these two processes, okay. So you have to pack the organ, and packing, there is a step there is a guidelines which we follow. So the National Transplant Organization, they have a guidelines, how they pack the organ from a donor to the recipient, how the gap is breached. Okay, the first bag, it is filled with a cold preservative solution. Okay, the procured organ is completely covered by the preservative solution and the well tied without any air. Okay, the second bag is wax impregnated fiber bag. Okay, it is filled with cooled NS or RL, normal saline or ringal lactate. Okay, then what happens, the first bag which is now packed, it is transferred into the second bag and completely covered with NS or RL. Okay, and it is well tight without any air. Okay, then now the second bag is packed into a third bag. See, we are having 3 bags, first bag, second bag and third bag. Okay, the first bag is filled with a cold preservative solution. We will come to the cold preservative solution. Just remember, the first bag is packed with cold preservative solution. Okay, the procured organ, now the organ which you have taken from the donor, it is completely covered by the preservative solution and the bag is well tight without any air. Okay, now this second bag, which is a wax impregnated fiber, is filled with cooled NS and RL. Okay, now the first bag which is now packed into the second bag. The first bag is packed into the second bag and completely covered with NS or RL, used well tied without any air. So in the whole packing process you can see air is avoided. Okay, now the second bag is packed into a third bag without air and well tied. Okay, now they are placed in a ice box. You don't think that the organ is taken, retrieved and directly put into an ice box. No, these packings are done, then they are put into an ice box, and that ice is, it might be a non-sterile, means sterility is not required. It might be non-sterile melting ice, and the box is firmly closed. So the organ is ready for transportation. Okay. Now come to warm versus cold ischemia. I will come to that solution, preservative solution I will teach you, but meantime understand what is cold ischemia and what is warm ischemia. See, warm ischemia refers to a tissue or organ experiencing a lack of blood supply while still at body temperature. Okay, meaning the damage occurs at a normal body heat. Okay, whereas cold ischemia refers to a tissue or organ experiencing a lack of blood supply while being cooled, allowing for a longer period of time before significant cell damage occurs. Okay, so essentially the warm ischemia is considered more damaging due to the faster rate of cell death at normal body temperature compared to cold ischemia. Obviously, in cold the process becomes a bit slower. Okay, so as a dictum, when the kidney will stand a long ischemia for 72 hours. The kidney has that potential. Okay, it can withstand that. Now coming to the storage. The main goal in organ preservation is to maintain function of the organ and tissue during storage so that the graft will function at reperfusion. Okay. So approach for the preservation of transplantable organs. So what are the approaches? The static cold storage and normothermic machine perfusion. So in static cold storage you have this UW solution. It is University of Wisconsin solution. I am coming to that solution. Okay. See, this is University of Wisconsin solution. So the temperature of this solution is 4 degrees Celsius. What are the constituents? The constituents are adenosine, hydroxyethyl starch, allopurinol, glutathione. Okay, and each of these constituents have their specific role. So what is the role? Adenosine will provide energy. Hydroxyethyl starch, that also will provide energy. Allopurinol and glutathione, they are doing activity of free radical scavenging. They are free radical scavengers. Coming to lactobionic or lactone, they act as a stabilizer. Okay, it is injected into donor through aorta and portal vein. Okay, so what are the effects that we get? Flushes out blood that prevents thrombosis, cools organs that decreases the oxygen requirement, and replaces normal extracellular fluid with preservation fluid. Okay, so University of Wisconsin, what the temperature should be? 4 degrees Celsius. It contains, what is the role of lactobionic acid? Stability, to provide stability. What are the constituents that gives energy? Free radical scavenger action is shown by the constituents. Yes. So, and what are they helping in? This solution is helping in? Yes. Now coming to normothermic machine perfusion, we saw that there is the approach for the preservation of transplantable organs are of two types: static cold storage and normothermic machine perfusion. We already learned about UW solution. Okay, now we will be studying about normothermic machine perfusion. Storage of organ in normal temperature. Okay, so the organs are heart, lung, liver and kidney. Okay, the advantage is more physiological state. Okay, means the state in which the organs are normally in the body. Okay, restores function ex vivo and replenishes the depleted ATPs, thus help in early graft function. Okay, they helps to prevent depletion of ATPs. Okay, so the graft, when we are giving the graft to the recipient, that there is early graft function. Okay, maximum and optimal cold storage time. Each organ has its own cold ischemia time, maximum period for which the organ can be kept in solution. Okay, so this is the chart where you can see the organs and their optimum hours for which they have their own cold ischemia time, and that is the maximum period for which the organ can be kept in the solution, and the safe period, safe hours. Okay, so kidney has an optimum hours of less than 18 hours and maximum 36 hours. Liver less than 12 hours and maximum 18 hours. Pancreas less than 10 hours and maximum 18 hours. Small intestine, there is intestinal transplant also. Small intestine less than 4 hours and maximum period will be 6 hours. Heart less than 3. So this is a potential question. The least is of heart, less than 3 hours and maximum safe hours is 6. So lung less than 3 hours and safe period is 8 hours. Now coming to graft rejection and transplant rejection. Okay, host immune system rejects the transplanted organ, recognizing it as a foreign body. Obviously we have an immune system which will be acting as, it will be treating that transplanted organ as a foreign body. Okay, so what we are using, immunosuppressive drugs. What are they doing? They suppress the immune system of the body to promote the graft uptake. Okay, in humans the MSC is called the human leukocyte antigen. Okay, and is located on the short arm of chromosome 6. The immune response to a transplanted organ consisted of both cellular lymphocyte mediated and humoral antibody mediated mechanism. The T cells, the CD4, CD8 are the major in the rejection of grafts. So this is also a potential question. What are the cells that are responsible for a graft rejection? What are they? The T cells, CD4 and CD8. Okay, so the reaction consists of sensitization stage and the effector stage. Initial immunologic, non-immunologic ischemic injury which increases T cell antigen, which through MSC initiates macrophage mediated delayed hypersensitivity and also helps B cells to promote antibodies. Cytokines, natural killer cells, apoptosis also play in graft rejection. So what do you mean by apoptosis? Programmed cell death. So this system, you know, this system, they are what they are doing? They play a role in graft rejection. So we have to suppress the activities of these cells. Okay, so that the graft uptake is successful. Okay. Now coming to types of rejections, there is hyperacute rejection. Okay, so then there is acute rejection. Okay, and then chronic rejection. There are 3 types. If you are writing, then you can write types of rejection: hyperacute, acute and chronic. Coming to hyperacute rejection. So what is hyperacute? The transplanted tissue is rejected within minutes to hours because vascularization is rapidly destroyed. Okay. Hyperacute rejection is humorally mediated as the recipient has pre-existing antibodies against the graft, which can be induced by prior blood transfusions, multiple pregnancies or prior transplantation. Okay. That will already have a, what it can have, there will be antigen antibody reaction, the body will be having, or the body is already sensitized. So this time when again you are doing a transplantation, there will be a hyperacute reaction and that will lead to rejection of that graft. Okay, this is called, if it occurs within hours to minutes, it is called as hyperacute rejection. Okay, so the antigen antibody complexes activates the compartment system, causing massive thrombosis in the capillaries, which prevents vascularization of the graft. The kidney is most susceptible to hyperacute rejection. The liver is relatively resistant. This is a potential question, that hyperacute rejection is least seen in kidney transplant. Okay, and relatively this hyperacute rejection is resistant in liver. So coming to acute rejection, it occurs within 6 months of transplantation. If a graft rejection occurs within 6 months, it is termed as acute rejection. So acute cellular rejection is mediated by lymphocytes and lymphocytes against donor antigens. Okay. So humoral rejection occurs due to presence of low level donor specific antibodies or preformed antibodies. Coming to chronic rejection develops months to years after acute rejection episodes have subsided. Mind it. So there is a event of acute rejection episodes previously. Then the patient is going to land up in chronic rejection. Okay. So chronic rejections are both antibody and cell mediated. Okay. The use of immunosuppressive drugs and tissue typing has increased the survival in the first year, but chronic rejection is not prevented in most cases. Okay. So chronic rejection appears as fibrosis and scarring in all transplanted organs. Now coming to the treatment part. Assessment and monitoring, it is done by clinical examination, organ specific assessment like urine output, urine analysis, creatinine estimation, ultrasound of whole abdomen, graft kidney biopsy in kidney, then liver function test, liver biopsy, blood parameter estimation, these are done. And immunosuppression, we have the drugs like cyclosporine, tacrolimus, sirolimus, azathioprine, basiliximab. Okay, then steroids and monoclonal antibodies, they are used according to their regimens. They have their own regimen and we use it accordingly. Okay, so what are the complications of giving this immunosuppression therapy? Infection, development of carcinoma, hirsutism, alopecia, hypertension, nephrotoxicity or neurotoxicity. These are the complications of giving a immunosuppression to a patient. Okay. Now what are the immunosuppressive agents thereof? Like we give a induction therapy. It is used immediately after transplantation up to 3 weeks. Okay. Anti-lymphocytic globulin, human lymphocytes are injected into rabbit or horse to develop the anticellular. This is basically the microbiology part, how they are developed. It acts against the T cells. It inhibits cell mediated immunity, allograft rejection, graft versus host reaction. It is used in transplantation of kidney, pancreas and heart. It causes anaphylaxis, anemia, thrombocytopenia, then serum like sickness and these are the reactions. Then there is monoclonal antibody. Okay. OKT3 is developed by hybridoma technique in a monoclonal antibody which acts or blocks at TCR complex. Okay. The TCR complex, the full form is T cell receptor complex CD3, affecting the function of native T cell and cell mediated immunity. Within 60 minutes of giving the IV injection of OKT3, IT blocks the T cells function, removing the circulating T cells. The T cells CD8 and CD4 are responsible for rejection of the graft. So what are they doing? This immunosuppressive monoclonal antibody, what are they doing? They are blocking the T cells, okay, function by removing the circulating T cells. Problem with OKT3 is immune reactions. Okay, So often it is combined with steroid or indomethacin. Okay. Now there are interleukins 2 receptor inhibitor. Okay, a chain of interleukin 2 receptor is related to activated T cells, and they are basiliximab and dacilizumab. There are two anti-CD25 monoclonal antibodies which bind with a chain of IL-2R. These drugs are well tolerated through a peripheral IV line. Stops acute rejection with less risk of infection and malignancy. Okay, this is also similar to, it causes serum sickness or cytokine release, just like the previous one. Like monoclonal antibody, the interleukin 2 receptor inhibitors also cause this serum sickness or cytokine release. Now coming to rituximab. Rituximab is an anti-CD20 monoclonal antibody as a depleting agent on B cell. It is used to control humoral mediated rejection. It is used in heart transplantation. Okay. Alemtuzumab, it is an anti-CD52 human monoclonal antibody which is expressed in B cell, T cell, monocyte, macrophage. It causes prolonged lymphocyte depletion for 6 months. It is used along with tacrolimus in kidney transplantation. Steroid can be spared while using this. Okay. Now there is role of IVIG, means intravenous immunoglobulin, that is derived from plasma. What this does, this neutralizes the circulating autoantibodies, blocks the T cell cytokines, lymphocyte proliferation and the apoptosis. Coming to maintenance therapy. So the patient which has already received the organ, okay, means organ transplantation has already been done in that patient, we give a maintenance therapy to that patient. So all transplant patients require a maintenance therapy for a prolonged period of time. Different drugs are used like steroid and azathioprine. Okay, these are the commonly used drugs, and in steroid we have prednisolone. What prednisolone does is it inhibits cytokines binding of IL-2 to receptors, blocks macrophages migration and inhibits delayed hypersensitivity reaction. But it causes hypertension, peptic ulcer, cataract, diabetes, osteoporosis. These are all the complications of side effects of prednisolone therapy. Okay. We have these anti-proliferating agents. They inhibit the differentiation and division of lymphocytes by blocking the purine and pyrimidine and folic acid metabolism as a structural analog, like azathioprine. These drugs inhibit both humoral and cell-mediated immunity. Toxic effects are bone marrow suppression and hepatotoxicity. Okay, why hepatotoxicity? Because they are being metabolized in the liver. Okay. Now we have this leflunomide in anti-proliferating agents and mycophenolate mofetil. Now coming to maintenance therapy, we give this T cell directed immunosuppressant and they are cyclosporine. Cyclosporine is extracted from a fungus. What is the name of the fungus? Tolypocadium inflatum. Okay. Now the side effects are same like which I have seen in toxicity. You have seen in hyperplasia, gingival hyperplasia, neurotoxicity, tremor, hepatotoxicity, like the previous ones where prednisolone and all therapy. Okay. Now this is the maintenance therapy, the drugs which are being used. So coming to a good part is renal transplantation. Okay. The first successful kidney transplant in India was performed on February 2nd, 1971 at the CMC Vellore, Christian Medical College Vellore. Okay. So the first successful organ transplant in the world was a kidney transplantation performed in 1954 at Peter Brigham Hospital in Boston. Okay, the first in the world was done in Boston in 1954, while in India it was done in 1971 in CMC Vellore. Okay, so the indications of the renal transplantation is if the patient has a diabetic nephropathy, which is most common in adults, or glomerulonephritis, which is seen in the children. Okay. Now coming to extended donor criteria. Okay, the extended donor criteria has fit patient who are more than 60 years or more than 50 years, or two of the following. Two of the following what? Death due to stroke, history of hypertension, and serum creatinine more than 1.5. The criteria for an ideal diseased kidney donors are, what are the criteria? Should have a normal renal function, then without hypertension requiring treatment. Okay, without hypertension requiring treatment, without diabetes mellitus. Means the patient should be free of hypertension and diabetes, because the most common cause of No, the most common cause of kidney transplant in adult is, so the recipient, the donor from whom I am taking the kidney should be free from this disease. Otherwise, that patient who is receiving that organ will be already in a means in a that organ will be having complications. Means that patient might be having, if the patient is having suppose diabetes, the patient will be landing in diabetic nephropathy later on, and the damage is already in process, and now we are procuring that organ and giving it to a recipient whose kidney is already being damaged. So the use is nothing. That kidney will eventually, it will degrade, it will stop its normal function. Okay. So we have to consider the patient to give a good, organ which is in a proper functional state, physiological state. Now there are, in renal transplantation there are three types of donors: living related donors, living non-related donors, and cadaveric donors. Okay, cadaveric means the dead bodies. Okay, highest chance of success in any transplant, especially renal, is seen when the donor is the identical twin. Okay, so in that case the graft uptake, that ratio is much more higher in an identical twin. Compatibility should be checked by tissue typing, that is ABO blood group system and major histocompatibility complex. Coming to HLA. Now in HLA what we see? HLA class 1, ABC, there is in class 1 we have ABC, in class 2 we have DP, DQ, DR, and only ABC and DR are matched. We have HLA, we have to match the HLA also, HLA of donor and HLA of recipient. HLA stands for nothing but it's human leukocyte antigen. Okay, they are of class 1 and class 2. In class 1 we have ABC and class 2 we have DP, DQ, DR, and what are the things you should match in HLA? That are A, B, C and DR are only matched. Okay. Now the investigations in a donor: ABO compatibility, RH compatibility, HLA compatibility, in which we talked about AB and DR. Okay. Then KFT compatibility. KFT means kidney function test. Okay. If the parameters are normal or not, we have to see that also. Then you have to do a USG KUB, means kidney urinary bladder. Coming to renal transplantation, where evaluation of a living donor is also done. So what are the things we are evaluating? ABO, okay, MSC typing, renal function, kidney function test, that one only. Blood, what are the parameters we are looking into it? Blood serum, blood urea, then serum creatinine, what are the the values in that report. Then we do renal angiogram, okay, IVP, intravenous pylography. We do intravenous pylography, renal angiogram. Then the tests like HIV, hepatitis, they are also viral markers, what we say. Okay, usually left kidney is taken for transplantation because of long left renal vein. Okay, the left kidney is preferred because it has a long left renal vein. Okay, it is placed in the right iliac fossa with ureter connected to urinary bladder, renal artery to internal iliac artery, and renal vein to external iliac vein, and renal artery to external iliac artery. This is the way in sequence in which we anastomose the vessels. Okay, first what are we doing? Ureter is connected to urinary bladder, then renal artery to internal iliac artery, and renal vein to external iliac vein, and renal artery to external iliac artery. Now coming to the technique. Before the removal of kidney, the donor receives IV mannitol to prevent kidney ischemia, diuretics and IV heparin. Okay. After removal of donor kidney, protamine sulfate is given to the donor. Removed kidney is perfused with cold perfusion at 4 degrees Celsius. What is this solution? UW solution, University of Wisconsin. Okay. And cold intravascular electrolyte solution are used to preserve the donor kidney, that UW solution. Okay. First renal vein, then renal artery, and at the end ureter is anastomosed. Okay. So the drugs which we are using prior to surgeries are azathioprine, cyclosporine and prednisolone. Why we are using these drugs? To suppress the immunity, especially the especially Yes, and they are CD4 and CD8. Post-operative management, immunosuppression. So after we have finished our transplantation, we give a post-operative immunosuppressive therapy, post-operative, after the operation. What are they? Cyclosporine, azathioprine, prednisolone, antimycotic globulin and anti-lymphocytic serum. Proper fluid balance has to be taken care of, okay, so that the patient is hydrated, okay, we have to take the care of that also. So what are the complications? Complications are of what? Complications of renal transplantation, acute tubular necrosis, rejection, okay. Rejection, how do you identify the rejection? It is identified by percutaneous kidney biopsy, obstruction of the collecting system. So what do you mean by collecting system? Yes, the renal pelvis, okay, and the bladder all comes under collecting system. If there is any obstruction in the system, and in between those two things we have ureter, okay. So we have to see also infection, bacterial infection most common in first month, okay, viral infection most common overall. So the most common virus is cytomegalovirus, okay. Bacterial infection might be of anything, E. coli, okay, most commonly E. coli, it can be of any types, okay. So the infection which occurs after renal transplantation in the first month, most common that infection will be occurring will be bacterial, and in this overall, you know, after the transplant the infection is most common is viral, and that also virus, yes, okay, CMV virus. Then there might be urine leakage after transplant, okay. Hazards of immunosuppression will be there, that you know already, like hazards of immunosuppression, hepatotoxicity, infection by unusual organisms. Why will the unusual organisms cause infection? Because the patient is in immunocompressive state, okay. Now coming to renal vein thrombosis and renal artery stenosis, this is the most common complication. There might be renal vein thrombosis, what sir told, venous thrombosis is most common. Theoretically it is capillary thrombosis, but most common is venous thrombosis, okay. So this leads in decrease in graft function. So the graft function is decreased due to thrombosis, okay, and it is managed by anticoagulants. So in renal artery stenosis, what occurs, this is gradually in onset, and there is the patient presents with hypertension, there is decreased graft function obviously, and this is managed by balloon dilatation. What you dilate by balloon? What do we dilate? See, it is a radiological procedure. What we do? We we pass a stent, okay, in the renal artery, where we see there is a stenosis, narrowing of the vessel. What we do? We dilate. There is a self-expanding stent or a balloon, okay. What we do after we reach in that narrow passage, we expand that balloon. That causes widening of that vessel, okay. So then the blood flow to that organ increases, hence the function improves, okay. And this is done by investigation, CT angio. How come you know that there is a renal artery stenosis? How will you know? If you do a CT angiography, that will suggest you that the patient is having renal artery stenosis. What are the complications? Malignancy, skin cancer most common, squamous cell carcinoma. Hematological malignancy is second most common. Breast cancer, post-renal transplant, there is a case of breast cancer also. Chances, okay. Post-transplant lymphoproliferative disorder, okay. Epstein-Barr virus infection, high mortality rate, CNS involvement if it's there, then there is a poor prognosis, okay. The clinical features will be fever and lymphadenopathy. Now we will be studying about graft versus host reaction, okay. So graft versus host reaction is nothing but its active white cells in donor organs attacks the immunocompromised patient, okay. This is seen in small intestinal transplant, bone marrow transplant. Clinical features are extensive skin rash, GI disturbances like diarrhea, protein losing enteropathy, edema and liver dysfunction. This comes under a short note, graft versus host reaction, so I am talking about it, okay.